Could we try it to see if it works? Hello, 1, 2, 3. 1, 2, 3. Thank you. Did you share it? You have a laser pointer? Yeah. Yes. And if you have a headset, that would be better because I like to walk. Thank you. Mhm. And we can turn this maybe off. Thank you. Yes, comfortable. Yeah. And can you put it here? Do you have a slide changer? Thank you. 1, 2, 3. Hello. Okay, I think it's coming out, right? Okay. Just checking the technology, make sure the technology works. And put it back. It is on. Just going to be Since you are reading anyway, and if you agree with you, I want to get a little bit of a conversation with you about the website. We are going to wait for the chairman to come, but why not use the time for some additional information? So that sort of give everybody a little bit of an understanding about what we're going to talk about. Now, raise your hand if you do practice basis, practice the budget basis. So that's a good number. I thought we had going up. And where's the path if you do more than 10 practices about specifically? So you see that there? In the United States, if you do 5 practices a year, you are in the church. Unfortunately, that is the limit of there's going to be like those practices, okay? The chairman who told me he put the natural and good fear of practice in my heart. So I'm a person who does the 7 level, 8 level, minimum basis, 60 degrees of the 40 degrees of the day to day. I just show up to me another day. I'm this person who, when 500 children saying, you cannot have the 30% will kill you, and do a 1.5 certification on staying there later. But on the days I'm doing last days and on weekends, because she had a natural fear of spaces. But the only guy was the chairman who, by the time he reached the country, was doing a law. At last time, I made my African because he too told me. Now, the only guy who was sort of talking about the law was called at the time this Spanish was happened, was a spoken of 35 years. He did it for us spaces, and before the Quran spaces, then I was with him for the patient, and he talked to the patient exactly his words. Quran spaces are difficult, even though all due diligence, you still come to the wrong level. This is not a level, this is not about God to tell about the right thing. It is difficult by nature. And I, as a young surgeon, I was a resident then, I was just thinking, what are you talking about? Why do you making the patient insecure and right before the surgery and so on? And it's really actually, you talk about that I have young instruments surgeon explain that. More than 55 minutes of conversation. I watched him. I mean, as a surgeon, he's a surgeon. That was my level of surgery. So I just was observing that. He counted from below and above, both in the air and lateral, for 35 minutes. But I have some very long level. And this is not because this as the chain of that. That saves our sorrow. We lost is that was this conversation just before the surgery. That conversation about experience, knowing the nature of the correct spaces. Now, by grace of God, the correct apologies are more vague than the normal. But I can guarantee you, more often than you think, is more often we have graphic topologies which you decide which the benefit just unjustified to do the surgery because all the technical problems come to the right space. Now, we are very good at doing methods for robots. Because that's part of how realize we solve it. Because we have different classic, like numbers for robots, and so you understand that in those sectors we are moving posterior, and they rarely do interbox reasons. Now, since we are so grateful and we can continue this multiple technology, how many of you have seen two parameters which could change pain? If you two parameters could change pain, you have interbody. The consequence is going to be that we are not going to do that quantity. There is nothing anything from this area, because we didn't have a solution until 2005 or 2004 reaction. We didn't have really good way of developing that. And for that reason, we thought the energy. This is correctly considering on a lot of often but if you look at it carefully, if you always suddenly have the tool to treat that and you look for the signs, it's more out there than you think it is. I think sometimes it's not a thing to situation because we don't have a solution for that. We just say, okay, I don't know what to do, or get out of here, or office is little by little learned, and we never take on it, and we just neglect it, just let it go down. The other thing, that in the situation, that I noticed sometimes a little different in my heart. This is just about the technique. So I'm not really talking about the diagnosis. It seems that by the grace of God, generally not here, so I have a little more time. I'm going to give something about the diagnosis of the drugs. This patient will usually commonly complain about the pain in the thoracic region. In about 2/3 of the time you ask carefully, the pain does circulate out, so there is some element of the block there. And because of the research benefit, I never talk on that alone. I can start the session. Oh. Could you put this on? So continuing that, my protocol.
Dr. Deshpande, Ethan, and Girish, come as the chairperson. Please come. I think you have to talk over there. Ethan, come please. And I request Dr. Please come. You are the chairperson.
Yes, this is Jugaad. This is Jugaad, making things work. Good job. Hey, can we put Dr. Anjum as well as the chairperson here? Dr. Anjum, it seems we need a chairperson. Come over here. No, I'm not kidding. Come over here. Go. Hey, I found another chairperson.
The main discussion, they want maximum audience. That's why.
Oh, okay. So, okay, that's fine. If we can wait. That's not a problem. But I would like to use the time for proper use rather than just waiting. Sure. I'm okay to wait. But if you are going to wait, let's put it to good use. So, discogram. Okay, now, part of my protocol for thoracic interbody fusion is the discogram. Now, I'm going to talk a little about the discogram. In the United States, half of the people believe in discogram, half of the surgeons don't believe in the discogram. And either one is okay, but a discogram is a tool. Now, please raise your hand if you routinely rely on discogram for your indication. Very few hands, okay? I saw 4 hands going up, and probably that is about 15 to 20%. Now, I know that you might be on the verge of yes or no, but if you believe discogram is a useless test, which is okay to believe that, okay? If you believe discogram is a useless test, you raise your hand. Good. You see, there are lots of people between. There is equal amount of people who usually use it and don't use it. Let me tell you, there are papers all over the place, and it goes both ways. There are papers that say discogram is a very useful tool. There are lots of papers that say discogram is a useless tool because it doesn't correlate, but most of the papers are very old. And we need new data, and hopefully you guys do those new data. The papers, I just want to tell you that, number one, the discogram that was done 20, 30 years ago is not the discogram we do today. We don't rely on the morphology alone anymore, okay? The discogram we do as well, we use something that we didn't used to use, which is the compliance of the disc. Now, I'm going to just ask Dr. Anjum, do you have a car? You don't have a car. Amanda, you have a car. Tell me, what do you think was the pressure inside of the tire of your car? PSI. 32 to 35. A normal disc gets 3 times more, and only 3 times more pressure inside of the disc, which is up to 100 PSI. One of the, I think, most advances of discogram that has happened just in the last 10 years, we don't just rely on the morphology. Obviously, we start using that, increasing the pressure, and see if the patient has the usual pain. We call it concordant pain. But one of the most important thing I think has happened in the last 10 years is that they put a barometer on when they pressurize the disc, they see at what pressure the pain was provoked. We call that compliance. Like you see a curve that at 10 PSI, the patient had 3 of 10 concordant pain. At 25 PSI, patient report 7 of 10 concordant pain. And or we see on some people that the concordant pain comes at 70 PSI. There's a huge difference here. If you have under 30 PSI concordant pain, that's a very different situation. So I'm going to step back. So I used it just last work. I used it for the thoracic cases. I use the discogram as a confirmatory measure, not to make a diagnosis or the indication as a confirmatory with the normal control level. So compliance, morphology, that morphology and the symptom align, and negative control level.
We start the next session of alternative interbody fusion techniques. May I invite Dr. Nikhil sir, Dr. Jawad Jethwan sir to chair the session. Thank you.
Thank you. Thank you, Dr. Abhijit. Yeah. So thank you for holding on the stage, giving us insightful information. Dr. Jethwan. So just a little bit late, but the validity got over just now. So we start with the alternative interbody fusion techniques, and we have an interesting panel of speakers here. So the first section is going to be homogeneous thoracic fusion by Dr. Abbasi. So we are ready. So should we start? Yeah.
Well, thank you again for having me here and listening to my mumbling for last 10 minutes. But let us start actually with the direct thoracic interbody fusion. There are 2 techniques I use for thoracic areas. One is the so-called direct thoracic, as it says, you are directly going to the disc base. The other one is so-called OTIF that we are going to publish a paper very soon, where you go obliquely to the disc. There are different indications for each of them, but today we are going to talk about this one. And as you know, the thoracic discs problems are rare. I laid the groundwork, so I'm not going to talk much more about this right now. I do about probably 15 to 17 cases a year of this, and I do equal amount of so-called OTIF, oblique thoracic. So my volume is about 30 to 35 cases a year, which is considered for thoracic cases a very high volume. People travel from entire United States to me, literally, because for good reason, we try to stay away from thoracic cases. So this patient find me online, they come to me. Now, what did I do before I did that? In cases that there is truly reason for thoracic interbody fusion or decompression, first, I would obviously, I'm coming from the back. I used to come from the back. At the first level, I would do a laminectomy. For some cases, that's enough. You do laminectomy, you cannot retract too much in the thoracic spine. Then after that, I would do a so-called facetectomy for some cases. That is enough to get to the pathology without distraction. If that's not enough, you do coastal triangular nephrectomy, and that is probably for most of the cases. And in some other cases, you go even to a pedicle osteotomy, partial osteotomy. You literally teletonize the spinal cord. And most of the spine surgeons are really well trained to do that. You're staying away from the peritoneal space if you do it the correct way. And then once you skeletonize, it's actually amazing how much you can do. You can, I'm not sure if I put that or deleted that slide. I have a actual picture of it. You see the nerve root above, nerve root below. You can literally, the whole spinal cord is floating around. In a good hand, that takes about 1.5 to 2 hours to get there, because you have to be careful when you do that. Now, and if you need to go truly anterior, this is the technique I used to use. Meaning that, you resect the rib, sometimes too surprisingly, you can do that without major consequences. You can resect one rib and you don't even put the rib back. You just take it out. Obviously, you need a thoracic surgeon to do that. You collapse the lung. When you collapse the lung, that is what you see. You get a direct approach to the disc space. And obviously, you're just looking at that, your indication to do that surgery is very high. You have to have a good reason to do that surgery. So entry point is very high. You're not going to offer it to everybody. Now, I think about 800 of all of them DLF, and I talked about that before I endeavored in this field. So I was really comfortable with the instrumentation and so on. And then what I noticed that you can use the same technique in the thoracic. By then, lots of surgeons have been doing XLIF-like surgery. XLIF is obviously in lumbar spine, but a handful of surgeons in the United States start using the XLIF technology to do that. And that really gave me the courage to do the direct thoracic one. Now, obviously, the setup is like the OLIF. The instrumentation is like the OLIF. You listen to the talk. I'm not going to repeat that. And then, this is what I start. I start a small incision based on the measurements in the intercostal space. And as you know, if you're going to enter the cavity, you stay above the rib because neurovascular bundle is just below the rib. So practically, I make a small incision, and then I usually make the incision a little lower, then move the skin up, and then enter the cavity. The reason for that is that you want, when you take your dilator out, the skin move back like a valve, that you don't have a pneumothorax. And then once you enter and you feel it's a very thick membrane, you feel that you pop in an empty cavity. Then you take the dilator, I call it walking the rib. You literally follow the rib. By doing that, this is very dull dilator. You have to be extremely aggressive to do additional damage because it's very dull. And then you walk the rib. This is what I mean by that. You go walk the rib until you're at the rib, head of the rib. At that point, there is a drop. You feel it. You get, I get X-ray in AP lateral. You follow that drop into the so-called practically Cambian triangle at that level. Now, thoracic, the nerve roots are much smaller. And literally, I did both neuromonitoring, no neuromonitoring. It didn't really make any changes. So at this point, I don't really even use neuromonitoring for this. And then literally the next of the steps are the same steps as the OLIF as we have discussed before. So you go in, you put a K-wire in over the K-wire, you put the dilator in. Now it's important. One end of the dilator is sealed with the intercostal ligament. The other end of the dilator is actually sealed with the capsule of the disc. And once you put the tube is 8 millimeter inside, 10 millimeter outside. The tube as well is sealed on both ends. So meaning there is no opening to the pleural cavity. It's sealed on both ends, so you have a direct access from skin to the interdiscal space. Then you do with this instrument that we showed here. There are few instruments missing here that I had it after I've developed. This is the old system. And then literally you do an interbody fusion, and in some cases, in about less than 10% of the cases, I got a pneumothorax, but then it's open. What that means, you can put a small, I don't put a chest tube, I put a so-called pigtail. Are you guys familiar with the pigtail? It's what radiologists use often. But since you have an open thing, I get a grasp a forceps, put the one end of the pigtail in the cavity, bring it out. I put it, what I do, I seal it, I lock it. I don't put it to any system. But after the surgery, right after the surgery, I get an X-ray. If there is air, I connect it to the chest tube collection system. If it's no air, and I get, in my protocol, I get an X-ray in the PACU, a CT scan before patient goes to the floor. So if there is something there, obviously there is a big problem, your anesthesiologist will tell you. But if it's a small problem, then X-ray and the CT will show it to you. Then you connect the chest tube that you already put in, pigtail, not chest tube. You connect the collection system. So I'm going to stop here. I have a video, but we don't have time for it. This is how it looks like. And this is the stem. This is where I go in. These are the screw incisions. This patient usually go home within 23 hours. The only reason I keep them over the night is because I want to make sure they don't develop the pneumothorax. I have done probably about 70 or something of these cases, less than 10% pneumothorax. Not a single pneumothorax was delayed. If you have a pneumothorax, you have it right away. So I feel comfortable that, I feel more comfortable now that after the CAT scan, few hours after the surgery, if they don't have pneumothorax, to send them. Thank you very much. Now, there is a video online. These are my cases. I'm not going to show you, but there is a video online that if you scan that thing, please take a picture of that barcode. Then you see the actual steps on YouTube. Then we don't have to run the video. Thank you very much for your patience. Thank you. If there is any question, I can.
Yeah. So the floor is open for discussion. Has any delegate got any questions, Dr. Abbas? Yeah. Dr. Rafiq. Dr. Abbas, excellent talk. So what is the distance from midline to your entry point? How do you measure that? Same as Olivia?
No, actually, even in OLIF, the distance is not the same. See, there are some of my colleagues, they use a fixed distance for OLIF. They use like 11 to 13 centimeters. Even after 1,600, over 1,600 cases, I don't use a fixed distance. I get the AP through lateral, and then I use a equidistance. For direct thoracic, I use the 1/3 in the lateral view, 1/3 into the disc base in a true lateral. You see, you have to adjust it so the ribs are aligned. Then in the true lateral, I use 1/3 of the into the disc base as my entry point. So it's not a fixed space.
Yeah. One more question, great presentation. Question is, I think you said you use the histogram as a level. Can you explain how good of a prognosticator is that? Does
Well,
it work every time?
no diagnostic system ever works every time. But I can tell you in the patients that I have done so far, it seems that about 80% of them after the surgery, that pain that they came to me for, pain goes away. So it seems that with all my diagnostic there's specifically of that discogram, that is the last confirmatory thing to be 80%.
Thank you, Dr. Abbas.
Thank you.
Can we just make the application so I would like to call upon Dr. Leonardo. He's going to talk about the concept for a standalone orthopedic center.
Thank you.
And we are
Thank you. Thank you very much.
Maybe.